and the recording will be posted on the committee's webpage shortly after the meeting. Now I'd like to invite Pam McEwen, FTAC Liaison to the Universal Healthcare Commission, to call the meeting to order. Pam, over to you.
Good afternoon, Angela. I'm still getting myself organized here.
No problem.
So it's now 2:02, and I'd like to call FTAC's March 14th meeting to order. We will begin with a land acknowledgement today, and I wish to acknowledge that I join you from the traditional land of the Methow and Colville Confederated Tribes, past and present, and honor with gratitude the land itself and the people who have stewarded it throughout the generations. This calls us to commit to continue to learn how to be better stewards of the land we inhabit. And I'd like to give a warm welcome to everybody joining us today. I'll begin by giving an overview of the agenda. As always, Angela will take us through roll call, and we'd like to use this as an opportunity to allow the committee members to better get to know each other. When your name is called, can you also let us know what you're most looking forward to in the spring? And then we will vote on the January meeting summary, and that will be followed by public comments. Next, our consultants, HMA, will share where we are in the Commission's 2024 work plan and set context for today's focus on benefits and services in a universal system. And we'll begin that discussion with a presentation by Hull Washington on SB 5335's proposed benefits and services and financial analysis. We'll take a short break, and when we return, HMA will guide our discussion on considerations for an actuarial analysis of benefits across several payers. We really encourage FTAC members to be asking questions through both presentations and to provide feedback to help facilitate today's discussion. But I think we'll be able to emerge with the best advice back to the Universal Healthcare Commission kind of through your questions and comments. So thank you for that. And I'll turn it back to Angela.
Thanks, Pam. All right, let's go ahead and get started with roll call. And please remember when your name is called to let us know what you're most looking forward to this spring. So I will start with Pam.
For me, it's daylight. I'm not a big fan of the dark Northwest nights, so really enjoying the light and the days getting longer.
Likewise. Christine, and she did let me know she wasn't going to make it today, but just for the record, Christine. Okay, David.
Hello, everyone. I am here and looking forward to starting fishing season again.
What season?
Fishing.
Oh, fishing. Oh, that's right. That's awesome. Oh, nice. It's coming up. Eddie.
Present. Yeah, I think this was the same question that we had last time in some fashion, but I still look forward to the same thing, which is sailing, and I have to try out my new mainsail, so I'm excited to try that.
Oh, excellent. Sounds like an adventure. Thanks, Eddie. Esther. Esther? Ian.
Yes, I'm most looking forward to golfing this spring and summer.
Excellent. Thanks, Ian. Kai.
Yes, hi. I'm
Kai?
most looking forward to walking through our local arboretum and seeing all the flowers in bloom, especially the cherry blossoms.
Oh, I heard they're starting in some places. Yep. Nice. Thanks, Kai. And Bob?
Hi. I got a couple of fun trips planned. One in end of March, I'm going to visit my daughter in Australia. She lives in Sydney, and we're going to go down to Adelaide and tour the wine country down there. And then later, I'm going with some buddies to Madrid in Portugal and doing a bike trip from Madrid to Porto. So got some fun trips coming up.
Oh, that's awesome. Thanks for sharing that, Bob.
Sure.
Okay. And Roger. Roger, I thought I saw. Oh, I think you're muted, Roger.
He's muted.
Here, let's see if I can unmute you.
Thank you. All right,
yep, there you are.
Good afternoon. My near-term plans are to take a trip to Lake Chelan in the spring and to go up to Stehegan, do some hiking up from Stehegan into the backcountry of the North Cascades.
Nice. A lot of awesome trips coming up, everyone. Thanks for sharing. I'm going to go ahead and turn it over back to you, Pam.
Okay, so please join me in turning to the second tab in your materials. And I want to remind everyone that the recording of the last meeting is posted on our webpage. We use a consensus process for a vote on the approval of the January meeting summary. Okay, have people have had a chance to look at it? Any discussion or proposed changes? I think that might be a first. I propose that the minutes be accepted without any changes. Any discussion of the proposal? All in favor, please say aye.
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 Aye. Sorry.
I think we got it. Any opposed? I think we have approval by consensus. Next, we're going to move on to public comment. Committee members can find written public comments under tab 3. We allow individuals to sign up to provide public comment before the meeting, and we will start with those who've signed up. When you're called upon, please state your name and affiliation and before speaking. We will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your comments. Angela, would you please start with the names of individuals who've signed up to provide comments?
Yes, first we have Roger Collier, followed by Marcia Stedman. And Roger, we're going to make sure you can come off of mute. So we're going to go ahead and promote you, and we will see you on the other side. And Marcia will do the same for you. Okay, Roger, you can go ahead and come off mute when you're ready. Roger Collier, are you able to come off mute to give your comments? Okay, might be having some
Can you now hear me?
Yes, you sound great, Roger. Thanks.
Great. Okay, let's go. Okay, good afternoon. Originally I was going to make some comments on benefits, since that's one of the things on the program today. But I noticed there were some quite big problems with the Washington Health Trust promised savings included in your tab 5 meeting materials. So if you look at page 19 of tab 5, page 19 purports to show savings of $6 billion. But if you add up the itemized numbers, you get almost $4 billion less than this total. In other words, $2 billion, not 6. And that means only a 3% savings versus 10%. So first problem. Unfortunately, it gets worse. The page 19 savings assume that current ERISA plans will be included, even though the commission has decided against this for now. If we remove the ERISA savings, and that's about 2/3 of the private insurance savings, the claimed net savings disappear totally. Worse, in fact. The result is a net expenditure increase of some $3 billion. Clearly, this is not what we've been hoping for. I'd be happy to walk through these numbers with the committee, and along with Gerald Friedman's even stranger numbers on page 20 of tab 5. But that's it. Thank you.
Thank you, Roger. Next, we'll hear from Marcia Stedman, followed by Consuelo Echeverria. Marcia, if you want to go ahead and come off mute, please.
Yes, thank you. Thank you. My name is Marcia Stedman, and I'm a member of the Healthcare for All Washington Board of Directors, also a longtime advocate for universal health care. So I was pleased to see that the Universal Health Care Work Group is specifically called out in today's meeting materials. It's about time, but it's also way overdue. The work group actuaries studied a variety of benefit designs and financing plans and showed in 2021 that a publicly funded and administered healthcare system could save Washington billions of dollars in healthcare spending every year, and at the same time, provide all Washington residents with comprehensive healthcare. When they ran out of time to design the plan, they recommended the formation of the Universal Healthcare Commission to design a plan that would work for Washington state. Thus, the very existence of the Universal Healthcare Commission and the FTAC is due to the preceding Universal Healthcare Work Group. In today's meeting, we advocates are looking for a robust and focused discussion on the work group findings and the proposed Washington Health Trust. We've waited over 2 years for such a discussion, and there is no more time to lose. In 3 short months, the Commission's analysis of the trust will be due. I urge FTAC members to dig deep and have the robust discussions we so desperately need. Thank you.
Thank you, Marcia. Now I'm going to call Consuelo Echeverria. If you'd like to come off mute and please give your public comments.
Can everyone hear me?
Yes, you sound great.
Okay, excellent. First of all, thank you so much for all your work in trying to make universal health care a reality in Washington State. And I, like Marcia, would like to say, while I look forward to Andrew Stackhouse's presentation in Whole Washington's Health Trust, I look even more forward to the robust discussion that will follow afterwards. We worked very hard for the UHCC and the FTAC to be awarded this extra time to discuss, and we really hope that it will be used and not sidetracked by other stakeholders. I'm also a bit baffled and confused by the 2024 Universal Healthcare Commission proposed work plan. It still contains oversights that have yet to be rectified. For example, in 2024, the work plan, the 6th bullet, states Whole Washington perspective, but in fact, the Washington Health Trust analysis report requires that a bill analysis be shared by the report on June 30th, just a few short months away, 2024. I might remind folks that this is a request from the legislature to the Universal Healthcare Commission members. I look forward to I'm sorry, I'm losing my words here. I look forward to the changes in the timeline to reflect the June 30th deadline bill analysis and for the use of the extra time awarded to this meeting to be used in productive discussion by the committee subject experts who have so graciously volunteered their time and expertise.
Thank you, Consuelo. Pam, I don't have any more signups, but let's go ahead and open this up to members of the public who'd like to provide comments. And if you'd like to, please raise your hand. Catherine, I see you. I'm going to go ahead and move you over. So you'll get that invite in just a moment. Catherine, if you'd like to come off mute and share your comments.
Sure. Thank you very much. I'm sorry. I wasn't going to give any testimony today, but I did try to ask Dr. Friedman if he could attend, and I just wanted to share his email with you all. I don't know if you're all aware, but he's been going through cancer treatment for the last year or so. Anyway, he said, "Dear Catherine, thank you for writing. I'm doing about as well, parentheses badly, as the doctors expected. Extremely fatigued. I do not recommend cancer. My treatments, the cause of my extreme fatigue and brain fog, will continue for another year. So far, they seem to be doing what they are supposed to be doing, setting back my cancer. As for me, the doctors tell me that my body is running a marathon every day, and I need to accept that my job now is to heal. Frustrating, but all I can do. I wish I could go to the hearing in person. I wish I could go and Zoom and testify. I wish I could at least watch in real time. Instead, I will be escorting my wife to her doctor at that time. Sigh. I do hope to return to an active role in the fight after getting rid of this cancer in a year. So let us keep in touch and let me know how the hearing goes. In solidarity, Jerry." So I just wanted to share that with you and encourage you. We really need to move this forward. The studies have all been done. We know that we can save money by doing this. We just have to take that forward step and start doing what we need to do. Thank you very much for all your work.
Thank you, Catherine. And if anyone else in the meeting would like to come off and provide comments, please feel free to raise your hands, and I'll give it just another minute here. Okay, Pam, we don't see any more hands, so I think we can close public comment.
Okay, I want to thank everyone. Public comments are such an important part of what we do. So, and we really appreciate the time you took to make comments today, either written or in person. I'd like to welcome back Liz Argent from HMA, who will briefly share where we are with the Commission's 2024 work plan and today's objectives. You can find the work plan under tab 4. Liz, I'll turn it over to you.
Thanks, Pam. And I've had made this comment before, but I'm in my office, and ironically, when I'm in my office, sometimes the internet goes out. So if that happens, Gary will pipe up here. And I'm sorry about that. So it's good to be with all of you. And I have to also comment that I see 3 people wearing vests on this call. And I think everybody's hopeful for spring. So I love it. So just a quick reminder to all of you about where we are in our process and where we've been and where we're going. So obviously we're here today, March 2024, our FTAC meeting. The last time we were all together, we had a really robust conversation about Medicaid. And I can't believe that was it's a couple months ago. But really, that conversation provided very clear direction to the commission about, and was able to wrap up how the commission wants to handle different groups of potentially eligible populations as you take on this work of designing this universal system. And now they are looking at you to provide guidance on how what benefits should look like in this universal system. Another key thing that is throughout the work plan, and it was, I think, referred to a couple of times during public comment, is the task of evaluating the proposal by Whole Washington. So, so that's woven throughout the work plan and is part of what we're hoping is part of what the objective is today. So if we can go to the next slide, Angela. Again, I'm not going to go through all these months, but again, today, so we are going to focus on what the commission is asking you all for guidance on, which is the benefits. At the same time, trying to help the commission meet the request from the legislature from last year to evaluate the Whole Washington proposal. So we'll be spending a big chunk of time hearing about their proposal and what it outlines in terms of benefits and how they modeled those. Following that conversation, we're going to look at the previous, the predecessor group to this, the Universal Healthcare Work Group, what their approach was on benefits, and then just provide high-level information about the other states that have evaluated and made proposals around universal coverage to see what their approach was. All of that to be a grounding for all of you as we look to you for some guidance on how to move forward on modeling for the Universal Healthcare Commission. We also, as a request, as we were sort of leading up to this conversation, there were many requests about, is there a comprehensive grid that shows everything across different existing markets in terms of benefits? That has been very challenging to find. So we do have some comparison documents that we want to share with you from the populations that we've decided to try to build around going forward, as some sort of foundation for the conversation that we're going to have later this afternoon. So those are our objectives for today. And with that, I'm going to turn it back to Pam, and then we'll come back later and get through some other pieces of this agenda. So it's good to see you all.
Thanks, Liz. Okay, next we're going to hear from Whole Washington and the proponents of the Senate Bill 5335 on the benefits and services in the proposed Washington Health Trust. This is part of the Commission's directive from the legislature to examine areas of alignment between Senate Bill 5335 and the work of the Commission. That's been referred to, I think, by Liz and a couple other people today. Whole Washington's work to design a benefit package for proposed universal healthcare system will also help our understanding of this area and perhaps areas where there might be gaps. Whole Washington's presentation can be found under tab 5. There will be time after Whole Washington's presentation for Q&A and FTAC discussion. I'd like to welcome Andre Stackhouse from Whole Washington to present today. Thank you for being here, Andre.
Thank you very much for that introduction. I'm just going to share my screen. There we are. So thank you, everyone, and good afternoon. It's great to be back presenting for the 3rd time to this commission. And since it's the FTAC I'm presenting to today, we're talking about the financing and the economics of universal health care and how that impacts our thinking around benefits. I'm Andre Stackhouse. I'm the executive director of Whole Washington. And these slides are slightly different than the ones in your packet. I do apologize for that. But you can find the latest version of the slides as well as our previous presentations at wholewashington.org/commission, or send any questions to our email. And I was going to start today. It was so wonderful that Catherine was able to call in and read that statement from Professor Friedman. Dr. Friedman is an American economist. He has studied at some of the top universities in this country, and he's a professor of economics at UMass Amherst. And he ran an economic analysis in 2018 on the cost of healthcare in Washington State, the impact of single payer, and the financing of the Washington Health Trust, which was updated in 2021. And you're strongly encouraged to read those studies. If you haven't, they are available at wholewashington.org/studies. And they're really incredibly thorough, yet still incredibly clear and easy to read. And today we're going to do a bit of a comparative analysis between those studies and the work group report that's been referenced. And we'll be looking at the costs and then breaking down the financing of the Washington Health Trust. And throughout, we'll be discussing the core values and philosophy that have guided our thinking around essential health benefits and the financing decisions here. And looking down the line, we are really hoping to support this commission in their June 2024 report back on 5335 any way that we can. And just one more time to emphasize that, in our opinion, an incredible amount rides on what is in that report back. We are dying to know what you have heard across these three presentations, what you think of the Washington Health Trust, and how it impacts our work looking forward. And we really think that regardless of what form universal healthcare takes in Washington State, it's built on a foundation of a 10-year cost analysis, a budget, and a public financing plan. And so we hope that's something that we can all kind of jointly back, as well as legislative recommendations as soon as the November 2024 report. Because these are two bills that have died with the end of the 2024 session. Joint Memorial 8006 was intended to start a conversation with the feds on acquiring those federal waivers. In 5335, of course, we are very much looking forward to the report back on it, but that report back is going to come after the bill has formally died in the legislature. And we really want to create a productive and proactive process in which the commission is really studying and developing policy that's getting recommended to the legislature and passed in a timely manner. And that's really how we're going to know that this process is working. That's what we want to see this turn into. But diving into our definition of universal health care to kick things off, the removal of financial hardship is an incredibly important component of universal health care. And if the seeking of health care either bankrupts you or you choose to not seek care, we can't really call it universal health care. And so the three key elements identified here are uniform billing and reimbursement, significant public funding, and a nonprofit financing structure. And we're going to show how we have answers to all of that and why they really are key to achieving what we're setting out to do. But starting with costs, this chart here shows the inflation of healthcare costs since the 1970s. The blue line is inflation adjusted, and you can see that it's gone from about $2,000 to $12,000. So that's a six-fold increase over the last approximately 50 years. And in Friedman's 2018 analysis, he estimates the cost of healthcare to double over the next 10 years. And so we can really see how this is not sustainable. It's not buying us better access. So this shows that nearly 35% of Americans struggle to access care because of cost barriers, and that's nearly twice as high across an average of 9 national health systems. It's not buying us longer lives. So this chart shows the United States as a major outlier compared to peer nations. So the farther right you go, the higher cost per capita we're spending on healthcare, and the further vertical you go, the longer the average life expectancy. And you can see the United States is spending considerably more while living years less on average. This is reflected in Washington State. So this is from Friedman's 2021 study. And this shows the relationship between the proportion of people unable to see a doctor and the average premature mortality rate. And each of these dots on this chart represents a county in Washington State. And you can see a clear relationship that the more people who are unable to see a doctor because of cost, the higher a proportion of premature mortality. This relationship becomes even clearer when you look at the child poverty rate. So this replaces the x-axis with a child poverty rate per county, and you can see an even clearer relationship between that and premature mortality across all age groups. And this reminds me of this quote that we use all the time: of all the forms of inequality, injustice in health is the most shocking and inhuman because it often results in physical death. And so we see that across Washington state, people are unable to afford the care they need and they're dying because of it. And so why are they unable to afford healthcare? So where is the money going? So you can see that in a public system like Medicare, 98 cents to the dollars goes towards actual healthcare services. But in private insurance, nearly 15% more, 17% in administrative waste. And so this not only means that it's more expensive, but what Friedman's analysis in 2018 estimated was that if we were able to simplify the reimbursement process, which is related to that uniform billing, that's part of how you can achieve this simplification, that physicians would save nearly 6 hours a week and be the equivalent of a 10% increase in the available supply of physicians. So it's not only a waste of money, but it's a waste of the valuable human resources that actually are able to provide care. And when you look at how this is reflected in our total healthcare spending, you see that we are spending about twice as much as the OECD average on healthcare without achieving universal coverage. But when you break that down between public spending and private spending, what you see is that the United States' public spending is comparable to all of these other countries in which the public dollars cover the vast majority of all healthcare in that country. It is the private spending where we nearly double our total spending and vastly outspend every single other country, and yet do not achieve that universal coverage or that longer life expectancy. And so this brings us to a core guiding principle here, which is that cost analysis must always be based around total healthcare spending, because we're trying to actually bring down costs, and you cannot do that by shifting costs from public to private. All that does is decrease efficiency and reduce transparency. And so as the consumer of healthcare, or as the taxpayer, you are paying both of those. So we don't get to choose. These costs fall on all of us. And so it's essential to look at total healthcare spending to seriously talk about bringing down cost. And so the bottom line we're going to try to reach by the end of this presentation is that the Washington Health Trust has a financing plan and is fully paid for through public and progressive financing. It costs Washingtonians less than the existing system, and it does this while achieving universal eligibility and comprehensive coverage. So starting with the cost analysis, this shows the cost analysis across both the work group report and Friedman's analysis. So they have different methodologies, and the work group kind of tallied up different healthcare programs and finds 2022's total healthcare spending at a bit over $61 billion. Friedman tallied up different services, so actual healthcare consumption, and in 2018 found just under 80 billion in total healthcare spending. That was a 2019 projection, which was slightly reduced in his 2021 update to this analysis, though not significantly. And then both analyses look at the impact of universal healthcare in Washington, and we have a couple different ways of looking at this. So the work group looked at two different models, Model A and Model B, and then Friedman's analysis is really closer to a post-transition Washington Health Trust, which really makes it more of a Model A analysis. And so what we think we can kind of conclude from this is that it's not, Model A and B is not directly comparable to legislation, that models versus legislation are not the same thing. But we think of the Washington Health Trust as sort of Model B when first established, with a transition plan to become Model A. And so when we look at Model B, it finds a modest cost reduction of about $800 million per year. And that is maybe reasonable as a sort of lower end for our expectation of an implementation year. Model A had $2.5 billion of cost reductions in its implementation year. So depending on how close the implementation year resembles Model A, we would expect a cost reduction of between 800 million and about $2.5 billion. But what we find is that across Model A and Friedman's analysis, we start to find savings of between 5 and 13 billion per year. And that's really achieved through the consolidation within the public health trust. And so that begins to emphasize why we tend to recommend a very fast transition, because not only is it getting more people healthcare quicker, it also helps achieve the efficiencies and the savings as soon as possible. So where do these savings come from? And the work group basically finds that Model A and Model B both have the vast majority of their savings come through the elimination of deductibles, co-pays, and premiums. But what you find is across the board that Model A outperforms Model B in cost efficiency. And so, again, one of the conclusions that we begin to reach here, and this corroborates some of those other charts we looked at earlier, is that you may achieve universal coverage through a multi-payer model that is contracted through private insurers, such as Model B. But in order to truly address cost, you really do have to consolidate within public financing and public administration. Here's Friedman's savings analysis. And so he looks at both increased utilization, which we would expect if we get a bunch of people healthcare who can't currently access it. And so estimated between his two reports between 7 and 10 billion in increased utilization, but in both years finds significantly more savings than increases in cost. And so the savings typically distributed between provider and insurance administration and market power, bargaining power. And then in 2021, find some additional savings looking into a few additional categories. And this chart is from the 2018 analysis, but again, you can see that administrative waste is really eating away at both ends of the system here. So biggest chunk goes to insurance administration in that gray. Second biggest chunk coming in provider administration. And then the third biggest chunk is market power. And that really starts to, again, explain why it makes sense to consolidate as much as possible within a public trust in a single cost pool, because that's how you achieve that kind of market power when negotiating with, say, pharmaceutical companies and hospitals. And so our conclusion here, the greatest efficiencies and cost reductions come from the reduction in the number of payers in the system and decreased spending on private insurance administration, because that's really where we see the most waste in the system. So getting into the actual benefits then, this is from our earlier presentation. These are the essential health benefits that are actually outlined in legislation and sets the minimum standard. Of course, this could always be raised by the board if they so chose, but the idea here is really to meet all medically necessary care. And we did that by starting with ACA standards, and then attempted to expand and align with federal single-payer legislation like HR 676. And then we have, added some explicit language, which is always intended to be covered, but just wanted to make sure a few specific types of care and groups are explicitly covered so they're not overlooked. But the idea is to get all Washingtonians into a single risk pool through universal eligibility. And that's really only possible if you also provide comprehensive coverage, because if you have all people in that risk pool, but you don't cover the things that some of those people need, then they need to get that coverage elsewhere, and they're therefore splintering off into another payer. And so we are intentionally trying to provide comprehensive coverage so that we can achieve that consolidated single risk pool. We are intentionally trying to decouple coverage from employment, even though employers pay a significant amount into this system. And we are trying to shift people from private payers into public financing. And that allows us to maximally consolidate for the greatest cost efficiency. And so how do we actually finance this? We looked at how much it costs, and Friedman finds that about an additional 20 billion in state revenue will need to be raised. But starting by looking at the existing revenue. A lot of this comes from federal programs. This really looks quite similar to the work group report. But Medicare, Medicaid, CHIP, ACA subsidies, and fines, over $46 billion in available revenue. And so with the remaining, we have to ask, how do we publicly finance this system in a way that is progressive while keeping within the Washington state's regressive uniformity clause in the tax code? And that's going to be a theme that we sort of have visited throughout all of our iterations on the Washington Health Trust. And, the way that we have tended to understand the tax code is that all taxes must be uniform, which is another way of saying flat, which is another way of saying regressive. But that a minimum of 15 or a maximum of 15K could be exempted. And so that allows us to exempt some of the lowest income for any tax. And so this was the proposed financing for 5204, and all of these would exempt that first 15K. And the bulk came from the employer payroll tax, which has a 2% employee payroll deduction, so shared between employees and employers, which we'll show more in a second. A capital gains tax, 8.5% above 15K, and then an individual premium, and finds a surplus of over 12 billion. We revisited this, consulting Friedman's numbers, consulting our community, consulting Friedman himself, and concluded that that individual premium was not necessary and wasn't popular. And so we were able to remove that, leaving us with the proposed financing for 5335, still operating at over 10 billion in surplus. That's higher than the original analysis for the 2018 study. So starting with that employer contribution, it's 10.5% owed by the employer, with the optional ability to deduct 2% from employee payroll. So the employee would only ever pay a maximum of 2%, but the employer may cover any or all of that as a benefit of employment, and many may choose to do so. This chart allows us to sort of compare these rates to private insurance. So even though taxes are not paid monthly, there's a graduated exemption, and then when sort of broken down as a monthly cost, you see that at the 50th percentile, the employer is paying between $425 and $525 a month, the employee paying a maximum of $100. And so when you compare that to the average cost of private health insurance, this is incredibly competitive, because right now the individual is paying about $475 for an individual plan, and the employer paying nearly $8,000. And an employer who covers a lot of families may be paying significantly more. And so this is incredibly competitive with those rates. The capital gains tax has a sort of storied history here. So the original version of the Washington Health Trust was introduced with a capital gains tax exempting the first $15,000. And that was our way of making the overall tax structure a bit more progressive by basically the capital gains allows us to ensure that the high income people are paying a little bit more into the system while maintaining compliance with that uniformity clause in the tax code. In 2019, the legislature actually passes a capital gains tax that exempts the first 250K. Between 2021 and 2022, we make two modifications. We modify the employer spending requirement, and then in 5335, we drop the individual premium. And then in 2023, the Supreme Court rules that the capital gains tax is constitutional, exempting the first 250K. And so this begins to open up our minds to the idea that we may be able to exempt considerably more than 15K on our capital gains tax. And that's something that we're certainly open to considering. Except for I thought it was pertinent to point out a few things that happened in the 2024 session. I-2111 passes, which abolishes income taxes. That was sort of already the case, but kind of reinforces that. And then, of course, I-2109 going to the ballot later this year, which theoretically may repeal the capital gains tax. And so the tax code is something that's always changing. And so Yeah, that's right. I forgot about this slide that I added. Yeah, the other thing that I wanted to point out is the capital gains tax has brought in more revenue than expected and more than it had been projected to. And just a few things that we think are worth thinking about when it comes to the capital gains tax. Can we raise that exemption floor? Should we consider a wealth tax or other alternative? That was a recommendation from Bevan McLeod in an article in The Stranger, that a wealth tax be considered. And could the trust perhaps be solvent without the capital gains tax at all? We absolutely think it can be. But when we break down how that funding looks for the Washington Health Trust as is, you see the vast majority coming from employers. This middle section is that 2% employee payroll deduction. So this visualization assumes that all of that gets put onto employees by all employers, but depending on what they actually decide, more of this middle section could look in that light blue instead. And then a relatively small sliver for capital gains, which really shouldn't affect most Washingtonians. When we look at the impact that this has on net income, you really see it's only the top 1% that are paying only 10% more than they currently do right now. And huge increases on income between the 20th and 80th percentile. You don't see that on the lowest 20th percentile because they may not have an income, they may not have health insurance, they may be covered by Medicaid. And so while they get the incredible impact of healthcare, they don't necessarily see their income impacted. In 2021, this is not exactly the same analysis because the financing structure had changed slightly, but also it's broken down by income rather than percentile. And you see only incomes above 500,000 and more paying more. And so we think that the impact of universal healthcare in Washington is incredibly progressive. And here are a few further economic impacts that were highlighted in the 2018 study. An estimated 12% drop in mortality rate, which if that saves 7,500 lives a year, valued at $10 million a life by the US government, that comes out to $75 billion, or more than the entire cost of healthcare. The elimination of potentially over 6,000 or 7,000 medical bankruptcies in Washington state, an estimated 3% increase in employment with the creation of over 100,000 new jobs. And we believe that there are plenty of other impacts that require further analysis, including reduction of homelessness, increases in worker productivity, improvements to academic performance, mental well-being, family stability, social cohesion, reductions in addiction and crime. The economic impacts are really too many to calculate, but we need to look into the many potential benefits here on the table. And so to conclude things, we want to say that what we are sure of is that universal healthcare is financially achievable in Washington state, that the greatest source of waste and inefficiency in the existing system is administrative costs, primarily through private insurance, and that the greatest savings and cost efficiencies will come from consolidating into a single publicly financed and administered cost and risk pool, also known as Model A, also known as single payer, also known as the Washington Health Trust, which is a universal healthcare solution that bridges us from the status quo to Model B and eventually Model A, achieving universal coverage and saving us a lot of money in the process. Thank you very much, and I am very excited about the upcoming discussion.
Thank you, Andre. I am too. And what I'm really excited about is we're actually ahead of schedule, which never happens in this committee. So that should give us plenty of time to ask questions. And I see that Bob already has his hand up.
Well, I think you've made a lot of really good points here. I mean, the comparisons between the U.S. and the OECD countries is a very important one. And, I don't dispute your findings. Our healthcare costs are just completely out of control and double the expenditures in other developed countries. However, there are different approaches, as you well know. There's a single payer nationalized system, various countries like Canada and England, the UK. But there are also social insurance approaches, which aren't that much different than what we've kind of accomplished through the ACA and expanding insurance. The difference between the United States and these other OECD countries that have social insurance systems is they have rate-setting systems that control cost growth and price growth for all their providers. And we only have it on the public side, as you astutely pointed out too. We've controlled growth and spending on the public side, but we have it on the private side. So I guess my question to you is, well, two-part. One, how politically feasible is it to do a single payer system here with all of the, sort of social, political, economic changes that are required? You're going to have to eliminate the private insurance industry. You're going to have to potentially raise taxes, but then you've got all these waivers that you've got to get through that are incredibly complicated to try to funnel federal funding into the state to create a single payer system, when you don't really need to do that to emulate what some of the other OECD countries have done, which is a social insurance system that is private sector, public sector, but they've got rate setting that controls expenditures, which we don't have. So I guess two-part question. How politically feasible is it to do what you're advocating? And believe me, if I could wave my magic wand and do what you're advocating, I would do it. But I just don't understand how people think this is politically feasible or economically feasible. And why not look at the other approach the OECD countries have successfully followed, which is set up a regulated rate setting system to control expenditures and the open spending area, which is the private sector. So I'm sorry to be cynical about this, but I think there's another way that's a lot more feasible to get to the point that you want to get to, which I applaud your desire and your goals. But so it's kind of a complicated question, but I just felt, given my background, compelled to ask it.
Yeah, so I'll answer in a few ways. I think one of the most interesting healthcare comparisons internationally to the United States is Switzerland. It's the only country I'm aware of that has achieved a very competitive universal healthcare system through an individual mandate system, which is what the ACA was originally designed as, although that individual mandate has been severely weakened. Sure. But the interesting thing is, while Switzerland is able to achieve a pretty affordable universal healthcare plan through an entirely market-based individual mandate system, it actually is the least cost-effective of the OECD countries. And so I think it corroborates what I've kind of outlined before, which is that it is the private payers and the sort of splintering into more payers that is less efficient. To continue, and I'm happy to let you respond if you have thoughts on it. But yes, when it comes to the political feasibility now, so there are many, when we look at the past transitions that have been made, right? The sort of traditional model had been the beverage model. Single payer was the sort of politically feasible compromise because it allows a very clear division between the financing of healthcare and the delivery, as opposed to creating a fully public, healthcare financing and delivery system. And when we talk about what makes this politically challenging, it really is the influence of the insurance industry, right? And I think that the question is, with the size and the power of the industry and the amount of money that is on the table for that industry, right, is keeping this around rather than addressing it, is that politically feasible, right? Are we ever going to actually be able to address the costs when the costs are what is basically driving the bottom line of that insurance industry?
Yeah, eventually it's not sustainable. I mean, and in a long-term budget situation, the U.S. also creates problems. But I guess just very quickly, and I don't want to dominate the conversation based on this topic, but there are other European countries like France, Germany, the Netherlands that have social insurance programs. Switzerland also has a rate setting system on the private sector. So again, you have models elsewhere that are not single payer, that aren't like the model in the UK or Canada or what you're advocating, where they control the private sector spending and they have health expenditures that are close to half of ours.
Well,
without eliminating the private insurance industry, which ain't going to happen. And it's not just the private insurers that are against us, it's the hospitals that are against us. So you got two mega political entities that are not going to go along with your proposal. I think what you're doing, the work you're doing is great. I just don't think it's realistic. And I think there are other ways of accomplishing it by establishing rate setting systems to control price and expenditure growth of the private sector alone. Because as you pointed out at the beginning, the public sector growth is not the problem. It's the private sector growth that we have to rein in. So anyway,
so what I would argue is that it is not really a fair comparison to compare those private industries in those countries to the United States because of how regulated they are. And so I think that theoretically this is achievable through that level of regulation, but it's almost at that point comparable to a nationalized industry. It's not the same thing, but it is not nearly as driven by market forces as what we're talking about in the United States. On the political feasibility, I want to make one more point, which is that this commission has been put into an incredible position of influence. And I believe that the recommendations of this commission can be taken seriously by our legislature and passed. And I think that this theoretically can provide us a space to make those recommendations independent of industry influence and make them based on the quality of the policy and those recommendations. And that's really what I would like to see. But I want to acknowledge that Erin has raised a hand, and Erin is here to support me and is a policy consultant from Whole Washington, and want to make sure that she is given the ability to weigh in on this as well.
Sorry, my dog decided now was the right time to start barking. Thank you so much. I just wanted to weigh in and acknowledge that I actually relate to a lot of what was said, and it is actually a part of why we chose this path forward. I think political feasibility is a real challenge, and it doesn't matter how good something is. If folks have been burned by a system, they have trouble buying into a new one. So I actually acknowledge that, and that's part of why we chose this transitional period, which is very voluntary in what they participate with. It does establish the trust as a rate setting mechanism, and then instructs the healthcare authority to take all of the authorities that it has to try and align benefits and reimbursements to the ability that it can to that central rate setting. It also leaves room for the administration of that plan by private insurance groups. And so I do think there's room for that conversation to happen. Public financing does not necessarily mean that nonprofit insurers couldn't participate in a program where people sign up for one of them or automatically get enrolled in one that's taking new signups. So I think that at least I want to acknowledge that you're correct and that we did try to take an approach to address those things. We also believe that mandating employers, which is a big chunk of the private insurance group, to meet a specific benchmark of spending to create some alignment on the amount that employees pay for coverage or can be expected to pay for coverage, and give them that really, really beautiful publicly insured, public coverage that they can opt into with and meet that expectation. And if they're not ready in the first couple of years, they can maintain their current insurance and just make sure that they're meeting those same expectations of employee to employer spending.
Yeah, and that's it. I'm sorry, I had meant to include this, but I absolutely.
Thank you so much.
Yeah, I believe that when we describe the Washington Health Trust as sort of beginning as Model B, but over time becoming Model A, right? I think that transition is where that entire conversation happens, right? And it's where we see how much enrollment we can do. It's where we can see if we can acquire those federal waivers, and ultimately we may achieve 90 to 95% of what we want, without going fully to Model A, right? But that is part of what we would figure out by beginning this process.
Okay, so I want to go keep the conversation going. Ian, you had your hand up, and we don't want to miss whatever your question was.
I was just curious, based on the Supreme Court ruling with the capital gains tax, they ruled that it was an excise tax similar to real estate excise tax, which has a progressive graduated structure. So it's not a flat base rate. I was wondering if you guys had looked into that at all, rather than keeping a uniform rate, which would be similar to a property tax, which I believe is why they originally did it at 7% in case the court deemed it was a property tax. It can't be progressive. So I was just kind of interested if you had looked at other tax rates, or if 8.5 was a magic number to get you to your revenue needs.
We might have to consult with Professor Friedman on that one to be sure, but I believe that we had not been aware of another way of doing a capital gains tax, and 8.5% was sort of just the right amount to hit the number and get the proportion to have the impact we wanted it to have.
Okay.
Thank you.
Yeah, thanks. Yeah, Ian is here because of his expertise in the tax system. Hi, you have your hand up.
Yes, thanks so much for this presentation. I wanted to double click a little bit more and get your comments on savings due to administration, insurance administration, and provider, administration, as in contrast to price, market power, right? And knowing that in general, right, the disparity in healthcare expenditures in the U.S. versus other nations in the OECD are generally due to prices, right? And in Dr. Friedman's findings, at least, like administration seems to be the primary, with prices being secondary source of savings, right? And so just to do some quick back of the envelope calculations, it looks like administrative costs in the U.S. versus other high-income OECD countries is about 7% higher, right, per Kaiser Family Foundation and Peterson Center. And so looking at Dr. Peterson's own estimates of total healthcare expenditure in Washington State, that savings is about, if we were to be brought to the OECD level, would be about $5 billion versus the quote from Dr. Friedman of 8, right? So is it 8 or 9? 9 billion. So a little, substantially different. And that's if we could bring it all the way down to the same percentage of expenditures as other OECD countries. Similarly, with provider administration and hospital administration, the estimates studied there in terms of savings is larger than what could be found elsewhere, and would entail entirely eliminating the cost of provider administration for insurance. So wondering if you could expand on the savings on administration versus prices a little bit more.
Yeah, well, I believe he does address both, and you might have to look into the footnotes and the appendices to get a little bit more on the methodology. I can really only summarize his work. I didn't conduct the study myself, of course. And I think that it's very useful that we have 2 studies from him as well as the work group report, so we can kind of cross-check some of these things and get a few more data points on there. I know that many of his points of comparison, not necessarily in the raw numbers, but sometimes in a statistic that he kind of pulls out, he'll compare something like the cost of X in Seattle to, say, Vancouver, right? So a lot of the times he'll make a direct comparison to one country rather than maybe like an OECD average. And there may be various layers of optimism and pessimism in what exactly those choices are made. In my opinion, it's a pretty high quality study, but it's just one. And the more judicious we can be about it, the more we can go in with, a confidence, right? So I think that the Washington Health Trust, as well as Friedman's studies, provide an excellent starting point. It puts an actual structure on the table and then provides an actual cost analysis. It's not above criticism. And that's why one of the things we outlined on our sort of future work is that co-developed cost analysis, budget, and financing plan, because we think that to the extent that there are discrepancies, mistakes that have been made at any point, better ideas, changes to the tax code, that we are always capable of improving on what's out there. But the important thing is to put something real on the table that we can then actually run the numbers on.
Mm-hmm. Thanks. Roger? And you're on mute.
Just a side comment and then a question with respect to, kind of, Marty, as your energies mentioned about, running the numbers. It's been one of my experiences that when these exercises go forward, again, as I'm sure they will, a critical need to have, how am I trying to say, a broad consensus of participants in the analysis, and I'll be more specific about that, to add credibility to it. So one small example is in our state, we have the Caseload Forecast Council that's critically involved with making forecasts, these caseload forecasts for various programs. And it involves both the executive branch, key staff and representatives from each of the House and Senate. And that model has proved, I think, effective because not only is the analysis more robust because of that exercise, but the credibility it brings to the full discussion. And I guess I always come back in that because it's often said, well, thank you very much. We like your analysis, but we can, we don't know how robust it is. That point of that broader participation structure, I think, will prove to, if we get there, to prove to be useful. Let me ask my question. What I'm hearing said, and correct me on this, is I think we, in the work that FTAC has done today, have concluded, as have you, that you can't get to ERISA directly. So there are strategies about, payroll taxes, et cetera, your tax structure to try to draw money from that sector, if you will, into a funding stream, and hopefully through the disincentives bring those individuals, employers, hopefully into it. The other issue that my own mind has been the problems associated with Medicare. My own opinion is there's not a pathway today to bring in Medicare. I've said this before personally, that if I was CMS, I wouldn't give to a state Medicare unless I could really demonstrate in a very broad sense of being able to administer programs that more broadly. So this has kind of led me, and this is my own personal one, and trying to understand, you've mentioned a bridge period, from starting Model B or whatever. Now, what I kind of hear in that, and correct me on this, and it's something I've kind of been talking about, is consolidated state purchasing. Because in my mind, and I'll try to be brief on this, is if we look at PEB and SEB, the affordable folks in the exchange, and Medicaid, we're talking about something in the order of 40% of all people insured today that the state itself, in theory, is purchasing coverage for. And so I'm kind of, my own mind thinking, I see that as sort of this, a beginning bridge, if you will. Would you care to comment on that? Or when you're talking about from Model B to A, maybe clarifying a little bit more of your own thinking?
Yes, I hope I understand the question correctly, and I'm going to take a quick stab at it, and then if you want to clarify anything, I'll try again. But when it comes to Medicare, right, I guess the first thing to say is that there might be a disagreement in that we believe that there is a path forward for Medicare. The first being that Medicare is allowed to continue to operate as it does. It's a federal program with its own funding. But the second being that we are able to put a sort of public option on the Medicare Advantage exchanges that allows Medicare enrollees to supplement traditional Medicare with a fully publicly financed alternative. And that kind of shows you how that is Model B like, right? Because in Model B, we're maintaining several different public plans, as well as, potentially contracting some of them through private insurers. But trying to make sure that we set standards, right, and achieve universal eligibility and hopefully universal coverage, right? Model A comes from the consolidation of those various plans into a single risk pool and a single money pool, right? And that's achievable over time through the acquisition of federal waivers, through voluntary participation, through employer participation. And so, you know, in that sense, you know, our goal is basically to achieve universal coverage as soon as possible, and then achieve cost efficiency and, you know, administrative efficiency over time.
So where I understand the issue around Medicare, so maybe go back and just very briefly say, well, we can't get Medicare, so we're doing Medicare Advantage, you know, start, and, you know, one comment would be is there's 18 carriers out there today, so we're going to be competing in a pretty challenging market. But if you go back a step, what precedes that in your mind as part of these first steps?
I guess if I'm interpreting this as like a sort of what is the transition for this, preceding getting a Medicare, like there's sort of a good, better, best, right? I hope this helps. So the best, of course, is to receive the federal waiver in which we're able to fully integrate Medicare. The middle option is to put that public option on the Medicare Advantage exchanges. And prior to that, we basically would, you know, Medicare would cover the current people that it covers as a separate system. And, you know, we wouldn't necessarily be able to immediately get that public option onto the exchanges. And so at that time, you know, that's a problem with Medicare right now, right? That's something that we hope to solve, but it may not be the first thing we're able to solve.
I mean, I'll turn to somebody else. I asked my question, so I'll come back on to later because it precedes all of what about Medicare. It's the step before that. But
okay, I think we'll have time to come back to you, Roger. Gary.
Thanks, Pam. My question is two questions. The first one's kind of a follow-up to Kai and Bob's. I noticed on the chart that shows the 2021 estimated savings that there's an item of about $11 billion of what's called hospital price adjustment and about $2 billion in physician price adjustment. And am I right to assume that that represents a reduced reimbursement rate as compared to what is being received currently under the commercial system, number one, and number two? So if that's right, my first question is, how would that be achieved? And then secondly, have you analyzed at all what the impact of that reduced revenue would be on services provided by hospitals and physicians? You know, we just came from a meeting last week of the Carriers and Providers Advisory Committee to the Healthcare Cost Transparency Board, and it won't surprise you to hear that even modest reductions in revenue are met by hospitals with great resistance, and by the claim that access and their ability to care for their patients would be adversely affected by any reduction in revenue to them, much less reductions of the magnitude that I think are being assumed in the analysis. So I'm you know, we're all in one way or another trying to get to this question of price, and what we hear from you primarily is we're going to do something about insurance companies. And I understand we need to do something about insurance companies, but insurance companies are not either the sole reason why it's so much more expensive here than anywhere else, and they are not the sole opposition to a plan such as what you propose. So I'd like to understand better how you plan to deal particularly with hospital prices.
Mm-hmm. Okay, so I think on the question of the, you know, to start with where you ended that, insurance companies are not the sole source of price inflation. And, you know, to create a truly robust and resilient and fair public health system requires many different factors, right? And we are attempting to address what might be the largest one, right? The financing. It's like a huge chunk of this, but I don't believe that that means that we just immediately have all of the supply we need. It doesn't mean that we have as many hospitals as we need in rural counties and things like that, right? So we do need to look at this as something that is achieved over time through dedication and the political will to succeed. But when it comes to those line items in the analysis, I do believe that that is what that represents. I think that one thing to remember is that cost is not always reflected in one place, right? And so a lot of what we believe we will achieve is to simplify the work on the end of the hospital or the physician, right? Through simplified billing and other means like that, which again, it is still part of the balance book of these sort of financial centers. It's just not necessarily reflected directly in the reimbursement rate.
Thank you for that. My second question has to do with benefits, which we'll be talking about a little bit later this afternoon. And as you know, there are benefits that are mandated to be provided by the Medicaid program, which are not included in the essential health benefits under the Affordable Care Act. The one significant one and one expensive one are long-term services and supports. As I understand your proposal, those would not be included in the universal system. So the Medicaid program would continue to have to provide those benefits to Medicaid people who would be eligible for those services under the Medicaid program. And my question is, when you provided the amount of funding that the Medicaid program currently provides to the system as a whole, did you carve out the services that your system will not be providing, or are those included in the total amount of Medicaid funding that you that your chart shows goes into the system today?
I'm going to go ahead and actually ask if Aaron is maybe available to provide some support on this one, because I think Aaron maybe knows a bit more about the way that we do our long-term care. It is intended to be included, but it is a little bit more complicated than the rest of the benefits package.
So long-term care, as you guys know, has been a conversation happening in the legislature in Washington at the same time as our proposal. So we made a point of including language that rolls that in, but also providing a window for the trust to actually come up with how to roll that in, knowing that there was going to be existing policies passed before our proposal got to that point. So it actually pretty seamlessly works with the existing long-term care tax. It would just be a part of the total healthcare spending requirement. So whatever is paid towards that would help meet that requirement. I believe the other aspect of this question was the initial Medicaid enrollment. Under our proposal, the requirement, the transitionary period, has to do with being able to enroll in a Medicaid sort of publicly funded expansion plan. Their earnings from an employer would have to be considered, so that amount that an employer is paying either to ESD or some other funds would still have to be paid. But for a lot of our lower income families, working families, that would be very cost effective. Even if their employer was paying into something else, the amount they would be expected to pay to get those extra benefits would make it an incentive for them to join. And for a lot of the middle income workers, if the employers are required to pay for an individual that they're currently not paying anything because they don't offer that employee coverage, they're part-time, there's a variety of reasons why employees don't have their employer's coverage. Sometimes it's cost, they can't enroll themselves or their families in it. So this allows those individuals to, their employer will be required to make some contributions to their health spending. And if it's not to an employer-sponsored coverage, which for a lot of folks it wouldn't be, it would just get paid to ESD. Now they are eligible with no cost to enroll in that plan. So the idea is that every individual who's offered an employer coverage, we recognize they're not required to enroll in it. They can still choose to enroll. And if their employer is not paying into a private plan for them, and they still have to meet a spending requirement, they will pay it to the ESD, and that employee can enroll for the expanded benefits, which are covered by that additional funding.
Okay. Bob.
Yeah, I just wanted to echo the comments of Gary and Kai. The problem in the United States healthcare system with spending is not administrative costs. It is a problem, but it's not. It's swamped by the fact that prices are too high, and it's consolidation that drives price increases, which drives spending. And so I think if you're overemphasizing, which I think you did in your presentation, the administrative cost aspect and the problem was created by very complicated private insurance system. I don't disagree with that, but that's not the big problem. The big problem is prices driving spending, and that's where the focus of regulatory action should be. If you're saying something other than that, I think you're misleading people.
Okay. Did you have anything else, Bob? Okay, and Andre, did you want to respond? That looks like not. So.
I didn't hear a question.
Okay,
I'm not attempting to mislead anybody.
Okay, yeah, let's move on then. David.
Andre, thanks for your presentation. I appreciated the comments of the public commenters who are clearly enthusiastic about this as well. I'm thinking about the task that Liz described where, our job as FTAC is to ultimately critique or provide comment on this proposal to the UHCC. And I'm just trying to think through what would I offer in that commentary. And when I hear your presentation, it sounds like the desired outcome is similar to what the work group and now UHCC has laid out with getting to Model B and ultimately to Model A. And so then I thought, well, maybe the first area of critique is it seems like the proposal that you've outlined assumes that we could easily consolidate the different markets of Medicare, Medicaid, commercial, which you've probably seen FTAC has been working through those and determined that that's not easy. In the responses to some of the questions, I think I'm hearing you say, no, that's not a necessary component of the whole Washington proposal. So now I'm struggling to figure out, okay, where does the work we've been doing and the proposal on the table, where do those diverge such that we would be describing to UHCC something we agree or disagree with that's different from what we've already been doing as our work as FTAC?
Well, I think what I would say is that how do I put this? We want to hear what you think of 5335, right? The bill no longer exists. And so what we would like to hear is not just what is wrong with it. What we would like to hear are solutions. And so in our opinion, the bill offers solutions. It's not necessarily perfect, right? But we want to see this. If, for instance, you say, well, here's what we like about the bill. Here are a bunch of challenges we see or things that we do not think are sufficient at this time, right? Well, then can we write a new version of it that addresses those things, right? Can we come up with something that we agree to move forward on? Maybe the problem is that we need to find something easier to start with, right? Can we establish a governance board, a trust, and a public option, to start or something, right? But what we want to hear is not just the challenges, but what can we do to move forward? And that's really what we want to start to see getting, I assume from this committee taken back to the commission and then from the commission to the legislature. And so that to us is, we can study healthcare endlessly, right? And there's lots of studies about public health systems. Some of that has been done looking specifically at Washington State. Obviously, Washington State is a specific place that requires a specific solution. So yes, it's worthy of further study, but eventually, you know, we want to take those learnings and parlay it into real healthcare reform. And so if, you know, the answer that we're getting is that, you know, there are reasons why we can't recommend the Washington Health Trust at this time, what we'd really like to hear is, what then is the recommendation?
Okay, that's helpful. Yeah, because I would venture to say we're all here because we have concerns about the long-term sustainability of the system and the inadequacy of coverage. And I think, you know, the thoughts you're hearing people reflect are because we're authentically engaging in the conversation of how do we solve this problem. Where I'm struggling in this critique and commentary issue is, what are the solutions in the Washington Health Trust that we're not already trying to work our way through?
I want to give Aaron a sec because I see the hand, but I guess I want to say that, you know, I think what we did with the Washington Health Trust, the main thing that's different is just that, you know, we wrote it in the form of legislation and ran economic analyses on that specific legislation. And that basically allows us to, you know, have something specific enough to critique. I think that looking at the issues individually, right, and coming up with a sort of like knowledge map of that area of you know, that sort of intellectual area is useful, but at some point it needs to be synthesized into, so then what is the system, right? And so yes, ERISA, the challenges of, you know, reaching that sort of universal enrollment and stuff like that, we need to like study and understand all of those things, but what we want to get to is the proposal of the reforms to move us forward.
Okay, yeah. So last piece there. So if is it fair to say that a key tenet of the proposal is to unify all the markets and eliminate the administration of private plans? If, as a, let's just say FTAC is unanimous on this point, which we may not be, if we say, okay, there's a big barrier to eliminating or consolidating all those markets and eliminating the administrative component of private plans, is that a sufficient critique that then takes us back into some of the things that Bob and others have been pointing out?
So I want to give Aaron the actual opportunity, but you said in the chat, to the degree that it's possible and at the pace that it's possible, you know, and I think that we, in terms of the consolidation there, the goal is not really the consolidation. The goal here is universal coverage and to bring down prices. And, you know, that is something that I think, regardless of what path we set out on, right, it's something that is borne out in implementation. And so I think that we, you know, we'll need to see the extent to which that's possible. We'll need to see the extent to which the addressing of those real healthcare goals is possible without it, right? As I said before, you know, that Model B to Model A transition is intended to find where we want to end up sort of resting on that spectrum. But I really do want to give Aaron an opportunity, so I'm going to stop.
Yeah, I was going to ask for a point of personal privilege here, which is, may I ask my question? And then maybe give Aaron the last word because we're getting close on time. And I am just, you know, I wanted to jump in as facilitator. I don't get to do that. So I just wanted to point out a couple of things. One is that I think that we all agree on the goals here. And I hope you heard that from the people on FTAC. And one of the things that I personally am just always frustrated by is the fragmentation in our system. And I think that's a lot of what you're trying to address through your proposal is the fragmentation. And I think a lot of what we experience here at FTAC is just the barriers that poses to us in trying to reach real reforms. For example, the inability to get waivers for huge programs would make a big difference in overcoming fragmentation for like Medicare, ERISA. Those things are considered almost insurmountable at this time. So that's we agree with you. Fragmentation is what makes our system so unwieldy and so unfair to so many people. But also the fragmentation is some of the barriers that are most difficult to overcome. My other point, which we don't necessarily have to discuss at this time, but I think is really important in looking at the American health system, is we tend to assume that people are unhealthy because they don't have access to health care. But people are unhealthy usually because of the inequities in income in our country. And people, that's generally what drives it. And that makes us quite different from the other European countries in particular, and from Canada and other places in the world that don't have those inequities. And the health that they point to is only partially because they have universal access. It's also because of their education system, that people don't have food insecurity, they don't have housing insecurity. And they have access to things that we don't necessarily equally have access to in this country. So it has huge impact on health. Probably neither of our groups is discussing that right now, but to me, it's a key determinant of health that underlies what we're talking about. And as promised, I'm going to get back to you, Erin.
Thank you so much. I agree with you 100%. I just wanted to add to that conversation about the transition aspects. And I'm sorry, I lost where we were at. I lost my thought. But it had to do with the previous question, and I'm hoping someone could remind me really quick.
That would be David.
So Erin, I was just trying to think through, how can I personally provide the most useful feedback to the commission?
Yes. One thing that is, I think the goal of Whole Washington it's on there, but also just personal preference, having watched these discussions get halted by financing over and over again. We spent a lot of time trying to come up with a really creative and competitive and functional financing model for this. And I would, for one, love the critique and feedback, but also I agree. If you aren't happy with it, I would love to see another viable alternative for financing mechanism. I think that's a spot in which the conversation stops quite often in this policy making. So thank you for the work.
And if I could just say one thing to sort of address what Pam had said, I also agree about the many, many reasons why we are unequal and unhealthy in this country. But I think healthcare is a really specific issue to focus on because, at the end of the day, it's either a vicious cycle down or a virtuous cycle up, and I think that, it's incredibly important to establish first that, our health has that value and is worth it. And that's how you begin to, once that is determined that we do have that kind of inherent value, I think that's how we can begin to address many of the other inequalities. But it is just one, but it's also, we're often poor because of our inability to access healthcare, and then that makes us, it raises prices and all these things. So they're all very, very related. But Thank you, everyone. This was a wonderful discussion.
Yeah, I really appreciate the discussion. And for the FTAC members, great questions, great comments. And Andre and Erin, really appreciate your time that you spent with us today and the conversation that it inspired. And I'm sure we'll be talking again in the future. Okay. Angela, I believe we now have a 5-minute break. Is that right?
Yes. Everyone ready for a break?
I think so. So we'll come back. 3:36 is what I have.
Yep.
Okay.
Thanks, Pam.
Yeah, thank you.
And we are pulling up the slides, Pam, so that'll be just a second.
Thank you for the break, Pam. That was nice.
Pam, can you hear me?
I'm on mute. Okay.
A quick question before we move onward. I think there, at least in my own perspective, there's a number of questions that I think maybe all of us have, at least my own mind, to follow up with our colleagues who made the presentation. Is there sort of a vehicle that we recommend, or for the group that we might engage in to get a further understanding? I'll give one specific example. I remain totally confused. I understand the end point. I get that one, but they talk about a Model B in this transition. And I was trying to use Medicare as an example. I don't understand it if they do have it. If they don't, that's fine. But that would help, at least for me, to be able to give feedback to the commission with respect to the 53-55 proposal. I'm wandering here again. I mean to do that, but you hear what I'm saying.
I think my impression, and I'm going to ask the staff to help me out on this, is that kind of from a logistical point of view, I think the commission needs feedback from us today related to benefits questions. But we also needed to give whole Washington time on the agenda so that they could really present their proposal to us and we could start the discussion. So I presume we'll be coming back kind of full circle on that as we go along. And that I'm hoping we have a good chunk of time for discussion today, and we may be able to pull some of the things that came up this morning into the conversation later with Liz. Does that work, Angela?
Yeah, that sounds good, Pam.
Okay, but
thank you.
You're right, Roger. There's a lot left undiscussed and a lot to come back to.
Roger, you're muted again.
You went on mute a little bit.
Come on. Just to clarify, so we'll have the opportunity again to come back, critique, interchange. We're going to focus on benefits, and we'll thank you.
Yeah, I think we'll build it in, and I think we actually are required to formally have a response. So we can come. So there'll be lots of opportunity to discuss this further.
Stay tuned, John. Thank you.
Okay. All right. Welcome back. And so HMEA will be sharing what the Universal Healthcare Work Group did that preceded this commission in determinations and recommendations for benefits and services. So we will go through that, and then we'll begin the discussion and consideration for the commission's actuarial analysis comparing benefits and services across Medicaid, PAB, and the marketplace plans and the essential health benefits. So Liz,
thank you.
I think it's had some technical difficulties that look like they're resolved, is going to take us
right now. Right now, it's okay.
Okay, good.
So anyway, sorry if that does happen, but Gary is here and staff is here. So
good.
If we can go to the next slide, Angela, that would be great. So we're coming to the second part of our agenda, which is really to focus on providing some support to the commission on the benefits and services. And as we really touched on in the first part of this conversation, and appreciate all of you, and your engagement in that conversation, your guidance has helped get us to the place where I think it makes sense to be doing this. And so, because we've talked about the different populations and what is feasible, what isn't feasible at this time. And while, just to sum up where we're at, there's an aspirational goal to try to achieve parity for the individual populations to the extent possible, but financial unification with some of those groups is not possible at this time. But turning the focus to what can we do right now to align the groups that you can have some say over, that the state can have some say over. So that's where we're going today. And if we can go to the next slide, that would be great. Oh, Kai, I see Kai's hand is raised. Oop. Kai, did you have a comment? Okay. All right. And so I won't spend a lot of time on this. You all have seen this slide, and we just put this together to really just talk to just visually convey what is it that the groups, who are the groups that we're talking about, and what is the task ahead in terms of trying to achieve some alignment. And the groups that remain really there seems to be a path forward are those in Medicaid, folks in the small group market and large group market that are fully insured, and those in the individual market. Right now, Medicare and ERISA are just set aside, and the focus is trying to find some parity down the road for those folks. We can go to the next slide. Okay, so I mentioned earlier that one of the comments, questions, it may have come from FTAC or the commission, I can't remember because we've gone back and forth a couple of times here, was is there a grid that shows the different benefits across those remaining markets? And we could not find one. And so we decided to take a little bit of a different approach in terms of trying to tap your all's expertise on how we might move ahead here. And thought one of the best ways to do that is to just give an overview of what other approaches have been in this space, and then just have a discussion with all of you about what makes sense in terms of modeling the benefits and services. So just for folks who maybe don't know this, the other 3 states that we have heard about or know have looked at universal coverage or single payer options are California, Oregon, and Vermont. And this slide just shows what their approach was to figuring out what the benefits should look like. California used the EHB. They also did some modeling about additional benefits, including vision, dental, long-term services, and supports. Oregon took the approach of using their public employee benefit package, and they did that because their look at it considered it the most generous. And Vermont finally used an EHB-like standard, and they ran additional scenarios, including dental, vision, and long-term services and supports. Any questions or comments about those? I'm not immersed in the details of these, but just wanted to put it up for everybody to kind of see what else has been done in this space.
Liz, would it be fair to say that Oregon's PEBB would look similar to ours, of what you know?
Yes, and there's a slide at the end that I think kind of gets to this point that just recently came out from the OIC. So we can go to the next slide. So this slide just really tries to capture some of the discussion that the commission had during the February meeting. They really are curious about things like the average provider reimbursement rate across the different payers and how that might play into some of the inefficiencies and inequities. They also pointed out that many countries with universal healthcare systems offer minimal essential benefits package without cost barriers. They also looked at plans offering additional benefits that could be offered through the private market and introducing some cost sharing, though it could perpetuate inequities and disparities. So they really were grappling with those 2 things. They also recognized that what the state can't afford may be a moving target. And I think we touched on that a little bit in our conversation with the whole Washington folks, that cost is a relevant factor for legislators. There was a conversation in terms of should the benefit package be broader? Should it be aspirational? Should it be limited? There was a recommendation or a suggestion that we should begin with something aspirational to address population health and then determine the cost. And then there were some folks who thought we should begin with the budget costs, which may change what the benefits actually look like. And then finally, they recognized that Whole Washington and the Universal Healthcare Work Group did conduct some modeling that could be helpful to estimating the cost of the state. And notably, both those approaches use the Essential Health Benefits Plan. And I believe the Whole Washington folks signed off, but one comment that I think we need to get a little more clarity on is their approach towards long-term services and supports, because I wasn't totally clear on that piece. So if we can go to the next slide. So again, I mentioned this grid issue, and Gary alluded to it earlier as well. The reason this seems to be so challenging, and it's not a surprise to many of you as experts in this, is that because of this issue where we have different sort of overseers for Medicaid, the issue is that CMS requires the state to provide specific benefits for specific populations, as Roger kind of led us through. So it's really challenging to do an alignment of Medicaid benefits given all those different populations. And secondly, for the fully insured market plans, they're required to provide state mandated benefits that aren't necessarily required in the EHB. So there's real challenges here. And also, if you go through a lot of the different documents that we went through, you can see in terms of trying to create this common grid, the materials and documents that they have often are developed with these, I don't want to say overseers, but with these, I guess overseers or requirements in mind. So when you go on the PEB website, you'll see all this information about acupuncture. We have acupuncture, we cover acupuncture, we cover chiropractor. Whereas on the Medicaid site, it's very specific about limitations at this time, which is referring to the types of providers that need to be providing those services. So there's very different starting places for both of them. And I don't know if Roger, anybody wants to make a comment about that, but because of those issues, it made it really difficult to find a grid that did all of it in one piece.
Can I ask a question, Liz? Sure. We don't have to answer this now, but I'm thinking the Medicaid benefits that are unique across the systems I would be curious at looking how many of those are related to pediatrics, maternity care, and children with special health care needs, because that would be a way of thinking about them.
That's a great comment. And to the extent that we could, we took the different packages. And so we'll go to the next slide. And we started with the essential health benefits. So you can kind of see this is a grid from the approved benefits for 2025 for the silver plan. So we started here as this was kind of like the starting place that whole Washington took and the starting place for the Universal Healthcare Work Group and what a couple of the other states started with. And then you can go to the next slide. We put on here the Apple Health benefits and attempting to kind of do what you talked about, Pam. And this is really, I would say this benefit package is from a Medicaid managed care plan for the adult expansion population and the children population. And Roger can go into the technical details about exactly how those are coded in the system, but the things that are red are things that are not in that benefit package. And the things that are green are things that are different from the essential health benefit package that we saw at first glance. And down here for vision services, it does say not covered eyeglasses lens for adults. And that it doesn't have EPSDT on here because we started with which would be the kids packages. So we can go to the next slide, Angela. Oh. So we really just tried to flag kind of the big ones that jumped out at us right away. And then if we go to the next slide, oh, actually go back, I'm sorry. There's a note that's really important here. Additional Apple Health benefits, LTSS, interpretation, non-emergency transportation. And just notably, there's no cost sharing for Apple Health benefits. And I think we should amend this to say EPSDT because that's not in there in this list. Let's go to the next slide. So to your point earlier, Roger, there was a recent comparison that Wakely, which is an HMA subsidiary or part of our company, for the OIC, did a comparison of the UMP PEBB plan and Washington's EHB. And they were doing this in service of trying to reapply for an EHB benchmark plan to CIO. And this really jumps out at you. The comparison found that the PEBB plan is 0.24% to 0.54% more generous than the EHB that is available. So I think it gets to that point, Roger. Do you have any questions about this? You're muted. You're still muted.
Oh, no. Still muted. We can't hear you.
I don't want to approach this. let me back up one thing on Medicaid. There's always Medicaid.
Yeah.
When we think about this, I would implore us to understand that Medicaid is the broadest benefit design that exists.
Mm-hmm.
And that's
no argument. Yes.
And in my humble opinion, whatever comes out of a uniform benefit design, if I can use that term, that our state adopts to go forth health reform, will not be that comprehensive. And I would use the best example is long-term care. It's not going to happen now.
Mm-hmm.
But my response is that's okay, because in my personal opinion, there will be benefits that are not in a uniform benefit design that folks may want. Cosmetic surgery, that's not, urgent. And so there's going to be a supplemental market out there. And that being said, is for the Medicaid population, those that aren't in a uniform benefit design, call them this supplemental coverage. They're going to sit outside of the delivery system that's developed in the near term, because that's the way it is today. And that's okay. That group will have access to an array of services because of their income status that we're not going to be providing in our state anywhere in the near term. But it's not a conceptual problem, if you say. So I just want to reiterate that.
Great. No, and I think we can just go right in to this conversation, because I think that's a great point, Roger, and that's basically really what we want to have a conversation with all of you about today, is what is practical and what should the commission have modeled. They have dollars for conducting an actuarial analysis. So I guess question number one really is what you're asking or saying is there agreement, or does it make sense to not model out Medicaid for all? We should really have that conversation. And if not, what should we model? Is it PEBB? Is it EHB? So that's really what we want to hear. Is there something else? Okay, keep going ahead. This is your conversation.
Well, can I try one more and I'll be quiet?
Yeah, no, you don't have to be quiet. This is your discussion.
So in my mind, there's sort of multiple dimensions when we have a conversation about benefits.
Okay.
And leave aside what they are for a moment. And as I think about this, and maybe there's more here, but one is the services themselves, right? Are we going to cover this service? There's a second one, amount, scope, and duration for those services, right?
Mm-hmm.
Okay. There's a prior authorization that may or may not be part of that benefit discussion. There's a notion of supplemental benefits that said, well, they're, like cosmetic surgery that may be out. As we conceptually think about this, there's a separate piece that we're going to have to deal with, but not get so hung up on for a moment. And that's point of service cost sharing, because to a degree, it's a separate issue.
Mm-hmm.
Right? And it needs to be kind of looked at separately, how either you don't have point of service cost sharing. If you do, what's the philosophy behind that, and where do you put it? But again, that's a separate concept, or from my mind, notion than the services themselves. The two other things that come to my mind on this at some point, if we go down the line, is what are we going to pay folks? Is there going to be a standardized benchmark rate, if you will? Rate normalization was the one that our friends in Oregon use.
Mm-hmm.
Also, and yes, no to that. My guess is in the long run, there's going to be yes to that. But my point is that rates are kind of a critical component of the overall benefit design, but it's a separate segment of it, if you will, that I think needs to be separated out a little bit, so we're able to think about these things somewhat sequentially. And I'll just go through my last thing, then I promise I'll shut up. In my personal opinion, I've thought about a recommendation back that would talk about, and I'll try to explain what I mean by an actuarial analysis that included the following programs to provide to the Universal Healthcare Commission what am I looking for? A matrix of options upon which at some point in time they could consider, and cost factors are obviously going to come into play in them. But those include PEB and SEB, and I think pretty much they're the same. If they're not, then whatever the differences are ought to be one of these things. There's some 500,000 people in our state that get coverage through PEB and SEB.
Right.
And that's I think viewed as did Oregon, a relatively robust benefit design. There is Washington's essential health benefits. Another one is I'm going to use the third one is our Cascade Select plan, if it's still in the essential health benefits. And I should know that, but I don't. We've talked about Medicaid. And then I posed two others for thought. Is there merit to including in this big analysis Medicare, acknowledging that it's not going to be there today, but you can see what Medicare is? And then the last one in this would be the largest plan that's in the large group market. Now, maybe folks come around, and especially our friends at OIC, and said, well, you know what? PEB and SEB is it. So you don't, you're wasting your time going off and trying to find a plan to do an actual comparison. But the question is, if there is a difference, then that ought to be maybe included also. And that seems to me, that gives a range, if you will, for the Universal Healthcare Commission to really have a discussion about, look at all this, how do we want to be able to maybe segment this and take a bundle list that looks like it's meaningful for universal benefit design. But we've provided, or that analysis provided all those array of options. So that's my 4 cents. I'm sorry.
No, appreciate it. David.
Liz, I'm trying to figure out the level of criticality benefit structure is to the commission.
Mm-hmm.
What I mean is, if we were to draw a Venn diagram of the overlap between Medicaid benefits and Medicare benefits and commercial benefits, keeping long-term care off the table, I think there'd be a high degree of overlap, and they were just, similar to what this chart illustrates. There'd be these little slivers where certain programs offer different benefits, but it's not a huge component of the overall cost. And so the idea of spending time and money studying the ideal benefit design seems to me less important than some of the conversation we had previously around the structure of a unified system and the methods to set up pricing or consider changes to the way prices are set.
So I think I hear you saying, David, that you're anticipating that if we had a Venn diagram that compared the benefits, there likely wouldn't be huge differences in the benefits. The issues are going to be around things like amount, duration, and scope, or cost sharing, or that kind of stuff. Is that what you're saying?
Yeah, so I mean, they all cover hospitalization, they all cover
Right.
outpatient hospital
Right.
services, they all cover physician services. That's the majority of the total cost of care. And, when I think about these things, Andre had a diagram saying, let's start with the total cost of care. And that's usually my starting point when I think about the work that we're doing. And I don't see the question of exactly what the benefits are impacting the total cost of care very much, unless one of the considerations is the cost sharing side of the benefits, because benefits can be what services are covered, but then it's also what's the cost sharing between the insuring entity and the patient. And if we're talking about eliminating cost sharing, that gets into a significant cost discussion.
Oh, Pam, go ahead.
Yeah, I'm going to let you call on people, Liz. So a couple thoughts. One is that I was on a commission many, many years ago. I'm really showing my age, to do a universal system. Roger was, part of that as well. And one thing I would tell you that if we were actually determining benefits for a statewide system, there would be so many people on this call because there's so much vested interest in what benefits are covered and paid for. So things like acupuncture between 8 and 12 visits a year, you can get a lot of public pressure about those things.
Right.
I was just picking the smallest thing. So that's that, so these differences may not, from a public policy perspective, they may be easy to smooth out and be thoughtful and logical about, but from another point of view, there's a lot of heat about what those things are like. And then I'm kind of, maybe I'm influenced by a previous conversation, but thinking about the fragmentation that because people are divided into these groups, they're often demographically different groups too. Like Medicaid was originally really primarily for mothers and children. And then, the PAB is kind of an adult program, for adults and working families as well. The exchange is primarily adults. There are very few children in the exchange because if you need assistance to pay for care, you're going to get in under CHIP or Medicaid for your child. It's very, very likely, very few kids. So the benefit designs are somewhat done around those demographics as well. So I don't know if there's a way to deal with that or even if it's necessary. It's just that I think in looking at a broad benefit package, we're trying to smooth out those differences.
That's a really good point, Pam. And I think you said much better what I was trying to say in showing the different packages. It's like there are different groups here that we're talking about. And the way the benefits themselves and the way that they are communicated are very much designed towards those populations. So Gary.
Thanks, Liz. I think it would be helpful for the commission to get a sense from the FTAC. If we start with EHB, what additional benefits beyond the EHB would be useful to model in terms of costs? So as other state people, the universal, the working group and the other states have said, well, okay, we'd like to see if we could add adult dental, for example. We'd like to see if we can add vision. We'd like, so I think, and then the big dollar item, as Roger's pointed out, is long-term services and supports. And if the answer is that just doesn't seem feasible in terms of cost to have that be included, then I think that's something that the commission would value your input on. The second thing, as a number of folks have mentioned, is what would be useful to model in terms of premiums and cost sharing. And what would it cost? How much money would have to be raised through taxes, employer contributions, the other sources beyond what individuals are now paying? And I think that's important because if you look at exchange plans, for example, those plans are really high deductible plans. And so what has ended up happening is that although with subsidies, the premiums are reasonable and sometimes zero, once you need care beyond the most basic preventive care, the deductible is so high that for many people, it's beyond their financial ability to meet. And if part of the goal of this is clearly part of the goal of what we're doing here is to try to improve access and equity, then doing something about cost sharing is really crucial to that. So I think from your all's perspective, to help the commission understand, where you would like to see us go in terms of the modeling and understanding what those costs would look like, would be very helpful.
Hi, and then Roger.
Yeah, thanks for this. Combining comments from several of the prior commenters, wondering, question or comment number one is like, seems like the benefit generosity between PAB and EHB is almost negligible, right? In terms of percentage of PPM, and even the PPM dollars themselves, like nets out to be $12 to $30, $40 a year, right? And so what I see, I went ahead to the next slide and I saw that, the commission is considering actuarial analysis on Medicaid, HB, and PAB. But I wonder if to the other, commentators, query if it makes sense to just model something such as like the minimum politically or socially feasible, lightest weight benefit design, and then as increments, then model out the additional major benefits that could be added on, and then do it that way, as opposed to having two PAB and HB being, fairly similar benefits designs in terms of generosity.
Yeah, thank you, Angela. So Kai, I think I heard you say starting with what's like most likely feasible and then kind of having some additional.
Yeah, starting with the lightest weight. That is
Okay.
that is reasonable, that is practical. And I don't know, controversially, it may be less than even in EHB, but perhaps. And then modeling out, adding on various different increments of benefits. In both the qualitatively in terms of what is covered, like acupuncture or something, and then also as Gary said, the cost sharing.
Roger.
Yeah, I guess I maybe we're saying the same thing. Am I doing it right? Yep. Saying the same thing. I guess I would come back and again want to kind of advocate for a real detailed analysis, and it's going to require some actuaries to do that so we can figure this out correctly. But of using something like PEB-SEB as an anchor point. And because that means something to, at least I think folks, most in general, we have Washington's essential health benefits. And to your point, you can see when you do those comparisons, you can see where the differences are. I don't agree with that chart, by the way, because I don't see adult dental on there. That's not inexpensive. And this is one example. So I'm not trying to criticize, but I'm not sure that I fully agree with what I see there. And again, I'm going to use Medicaid. You can argue one way or the other about Medicare, and to raise the question about, well, how does PEB-SEB look in terms of the large group plans?
Right.
And if you do that right, you accomplish what my colleague is I guess asking for, because you can see
a menu.
Differences are. They can do an analysis that doesn't take into account price. They use a standard pricing so you can see, the weighting of those differences. That I think kind of then affords the opportunity, for the Universal Healthcare Commission to kind of pick and choose. The other problem is saying, well, if we start with something that's affordable, we don't know what that is. That's we got to build a benefit design, figure out how to finance it, and we turn around and say, geez, we can't do all that. I'll pick a classic example. We can't do adult dental, right? Surprise, surprise. Then that gets taken off. But your final benefit design is an iterative process.
Mm-hmm.
I'm going back and say, well, what can we afford? We don't know what we can afford.
Mm-hmm.
I would say we don't start there at all. We don't.
Right. So what I hear you saying, Roger, is advocating for or proposing that we come up with the menu that has there's a main course, I guess you would say, and then a number of a la carte things that they can sort of pick and choose from, but focus on.
Yeah, they can do that. I guess I would say they can do that from a degree of seeing what's out there now.
Yeah.
I understand this. You can say, well, you can start and have Milliman just go through and for basics, you got this, mm-hmm. It's kind of unmanageable. And I guess I'm kind of wanting to argue that we have some, like we see here, Medicaid, PEB-SEB, the essential health benefits. And I want to say again, Pam, because maybe you know this, if our own qualified health plans have a different benefit design than the essential one, well, what's that? And
yeah, I was going to say that at the exchange, I know this obviously, that because of the lack of affordability in the plans that Gary referred to, that's what incented the public option. and the standardized plans. And so in the standardized plans were designed specifically to bring value back to consumers on those plans and to steer people away from high deductible plans they can't afford. You know, kind of looking at kind of the latest and greatest thinking on a silver standardized public option might be a better benchmark than EHB. I think it should at least be placed up there and see if that would be preferable for the commission to look at.
Ma'am, can I add one other thing? I guess I want to go back and say, here are the benefits. And they, you know, our actuaries can do this. And you can say that then around those benefits, we can introduce cost sharing. Because I would say to us personally, if we were going to, somebody can say, are we going to have what we think of a universal health, you know, benefit design? I don't think we would end up with a silver plan. I mean, that was something that came out of the ACA, right? And, you know.
Yeah, you might say, yeah.
I don't see that as being a guidance to us, as opposed to the issue around as a separate analysis, which they can do, is adding in cost sharing components. Because what we'll hear from a lot of folks is saying, well, the heck with that. We want to find a deal that eliminates cost sharing altogether. I mean, we've heard that from folks, right? That in of itself is a robust debate, cost sharing or not cost sharing, what it is. I keep coming back and saying, in my mind, I think we need that as a separate dimension than the benefit.
Okay.
Sorry, I don't need to get
No,
off.
no, that's okay. I see Eddie. I see your hand up.
I was listening to Pam and Roger, and right on. The one thing interesting about the Medicaid, the rate setting, and so if it becomes a universal rate setting and the largesse of that purchasing power, is that what we modeled by the actuaries of how we could benefit from that? Is that like a unique thing?
Well, can I try to answer that myself? When we've done this in the past is when you do some sorts of benefit comparisons, let's say between Medicaid and PEBB, you don't use, you look at utilization and benefit designs, you come up with a standard price, you know, make up one that you do that benefit comparison around. Because it's true, if you're looking at Medicaid in terms of, you know, a PMPM for Medicaid, well, you got big benefits and you don't pay as much. And that doesn't really, what am I trying to say? That doesn't give you a reasonable comparison of the benefits themselves. And I believe, my own thoughts are being, and Oregon wrestle with this issue. At some point in time, it's like what Bob would say is, well, if we're going to do this, what are we going to do about prices? Bob articulately said is, we shouldn't, sure the hell shouldn't use commercial for all good reasons he's saying. But some time have to, you know, somebody's going to have to wrestle with that issue through a rate setting process. I really quite agree with Bob in that. You know, I'm going back to Oregon. I'm really wondering the rate thing. What they did is they said, we have a total amount of money and we're going to back into what a rate would be. And I'm going to make it up. It was like 140% of Medicare. Well, how did they get at that? Because they didn't want to spend any more money than they were today. And when you do the math, that was the indexing that, I'm sorry, the price indexing they were going to use. You know, not a bad way to start. But again, I come back and say on the rates themselves and how we drive cost savings and the like, it's kind of a separate issue than the benefit design itself. Well, I mean, it is a separate issue.
Yeah.
That's right. Does that answer? I should shut up.
No, I mean, it discusses more, but I mean, even in the current Medicaid system, the rates that providers get, you know, they still are able to share in profits that they make from what they did the services they deliver at the end of the year when they figure out what the profit sharing may be.
Well, I'll give you 3 examples, and we've talked about this before. And again, Bob will be more articulate about that. You say, well, Medicaid doesn't pay well to hospitals. Excuse my language, they bitch and moan about it all the time. I get that. Been there for 20 years with them. But we pump all sorts of additional supplemental payments to them. And looked at that, or MedPAC looked at it and said, you know, you look at that today, Medicaid is often paying more than Medicare is. I mean, you're not going to hear the hospitals say that, but it is the case. I'm going to use 2 other ones. We pay federally qualified healthcare centers. They're a critical provider and rural health clinics. Medicaid pays them better than Medicare. Well, they pay the same as Medicare, and both of them pay better than commercial. So, you know, it's I mean, go figure that one. Well, I know why it's there. It's there for we want to try to sustain access. So,
right, Bob.
Well, I heard my name. Hopefully, it wasn't in vain. Yeah, I mean, I sort of lost my train of thought, but I do think that the issue is prices. And again, to reiterate my point from before, we've got a social health insurance system in the United States now. It's not perfect, but we're up to over 92% of the population insured. It's the highest level we've ever been. That's a great accomplishment. What we don't have is a price and spending control system for the private sector. It's an open-ended financing system. And it's getting worse. I mean, it was created because we let all the hospitals, primarily hospitals, it's beyond that now, consolidate. So we have non-competitive markets now, and the hospitals have their way with the private insurers. In many cases, the private insurers benefit from higher spending and prices, you know, through the MLR and their ASO arrangements with the self-funded plans, which makes up 66% of the insured market. And they collude with the hospitals. So we can't rely on that. We can't rely on antitrust, which has failed. So in my estimation, the only thing that we should focus on at this point is not some grandiose, you know, single payer system, which I think would be lovely to have, but it's not in the cards politically or logistically. Focus in on controlling prices and setting up the same thing that the other developed countries have, which is a regulated pricing system for all of their payers, public and private. And you can unify purchasing power through an all-payer system, but you don't need an all-payer system. You already have public side is controlled. The private side's not controlled. So that's where I think energy should be focused is in that area. And it should start with states because the feds are dysfunctional. They won't get to that point. I mean, maybe in the next 10 years, when people wake up and see, you know, the budget crisis that we have looming, it will precipitate some sort of action at the federal level. But the states have the opportunity to do this now, and that's where I would suggest we focus our attention. Thank you for hearing me out.
So Bob, at the risk of putting words in your mouth, I guess the question I would pose to the group then is the group in agreement? I mean, you all are being asked vehemently by folks to do something to move this process forward. And Bob, what I hear you saying is there is no way to get to a universal, more equitable and affordable system without doing something about price regulation.
Absolutely.
You know, we have a transparency board that is looking specifically at that issue. It's decided that for this year, one of its priorities is to look at provider price regulation as a policy to examine and potentially make a recommendation to the legislature. And if the FTAC and then this commission would express a point of view that is supportive of those efforts, I think it would make a big difference. But it depends on whether, you know, I mean, you've framed the question, should we be talking about this, you know, designing this big, broad, you know, elaborate big change, you know, in the system that we have today, or should we be really grappling head on with the number one reason why healthcare is not accessible, not equitable, and not affordable, which is price?
Yeah, I agree 100% with that. And also that I think you have a much more politically possible potential of addressing it that way instead of taking on the insurance industry and the provider industry at the same time, you know, and then trying to get the federal government roped into a single payer, you know, providing funds flows. That's just a bridge too far. I applaud your desires and aspirations in that regard, but I just don't think it's going to move the needle in the right direction quickly enough. States have the opportunity to do this now, I think. I mean, do one quick point too. Look at what Oregon just did with their public and state employee benefit program. They put price caps on it, which is starting to generate pretty significant savings for that program. You know, price caps work. and they're set high enough, it's not going to put any of the hospitals out of business. It's 200% of Medicare. So why isn't the Washington State public program doing that? Or California? I mean, there's evidence out there that these things work. So I agree 100% with Gary.
Yeah, if it works, the other states will follow. I mean, that will definitely happen. One of the things that we've talked about in all the different iterations of this group, Liz, I think you've been there through most of it, is making, do you go to a whole new system that, it's single payer, or are the barriers too high to do that? And then you try to make what you've got work, which is what Bob's been kind of alluding to during this whole meeting. And as we do that, I think this group keeps identifying barriers, costs being a huge barrier. So that the problem is we do have access, just about everybody in Washington State has access to care now, but a lot of the plans are unaffordable because the thing is you can't make them affordable because of the pricing issues. So some of it is, I think what I'm trying to say in this is that, and kind of in response to Gary, is do we start, kind of cataloging what those things are, what those barriers are, in other ways we might get over them in terms of interim solutions or another way of looking at a universal system.
Pam, can I follow up with a comment? I think I agree with Bob. I put a challenge back to all of us is to say, we did have a hospital commission for a period of time for doing some work, and they got tanked. So my only point back is not to say negative about it. I'm just saying that, as Bob can appreciate better than any of us, that's going to be a real food fight. And we saw that with some stuff they were trying to do and looking at, what was it? Keep All Care bill. It was just trying to look at some market consolidation. Well, that bill got tanked. Why? Because the hospital association. So all I'm trying to say is not that we shouldn't do that. I'd want to propose again a similar structure that I keep thinking is doable, is consolidating state purchasing. And that consolidation at least gives and that's going to be a hell of a lift anyway, to start to do in that pricing structure. I'll give a specific example to try to attack directly, prices and rate increases. And then, in our own state, we have a deal where we got half the folks in plans, and we got other folks that happen in terms of state employees in an ASO model. Again, is through at least that consolidated aspect, you can go after putting price caps on payments, and you can put price caps on what you're going to contract with the plans for. We did that in Medicaid. It works. So all I'm trying to say is I see several pathways. I agree with Bob, but I also agree on this notion of trying to consolidate state purchasing, because I think it brings it, 40% of the folks who are insured today are through the state. Hell of a market, right? That's a hell of a cost driver. I mean, driving it down. So
Bob, I see your hand, and then I realize we're almost at time.
Yeah, I'll very quickly just
no, that's great.
Because Roger mentioned the Washington Cost Commission. I'm familiar with it. They, ironically or interestingly, they took the statute, because I was the executive director of the Maryland Hospital Rate Setting System. They took our statute word for word, but they failed in implementation. And I'm trying to do some research, and maybe you can put me in touch with folks in Washington that know more about the Cost Commission. But I've been told from folks that are older than I, that were either dead or retired, that it was all in implementation. So it's feasible to do. Maryland's proved that it's possible to do. And it's just a matter of finding the right course of action. I'm trying to write some articles about this. But anyway, I think it's totally feasible. Eventually, we'll do it. There's no other solution. And probably what will precipitate it is a huge fiscal crisis, just as occurred back in 1980 when Ronald Reagan, of all people, put in IPPS. He's the ultimate rate setter, ironically. But will precipitate it will be a budget crisis of some sort, which will flow back to the states, because states on average get 30% of their funding from the feds. So anyway, I think it's feasible, and I do think that this is where the solution is. And the sooner we get to this conclusion and push for it at the state level, the better.
Well, I think that Roger looking at the two of you, but so somebody will follow up with you, Bob. Oh, I'm having my internet connection be unstable. Can you all hear me?
Yeah, you're fine.
Oh,
Yeah, we
okay.
can hear you.
Oh, okay. So just to sort of wrap up, because I'm very mindful of the fact that we need to give some guidance to the commission about an actuarial analysis on different benefit packages, and completely recognize that we do want to continue to have this group grapple and make recommendations to the commission around cost, ways to address cost, because as we all are super familiar with, I hope by now, that secondary charge of the commission is to look at interim solutions. And this is a very perfect example of an interim solution that there's, as you noted earlier, Roger, there's been a lot of activity over the last couple of years to try to make some, get some momentum and move ahead there. But in terms of what's on the table for now, if we're trying to do a more consolidated consolidation among the state programs that we are able to, have some purview over, what should we have an actuary model in terms of a benefit package? Do we like this idea of a menu starting with PEB or EHB and then layering in like other things like LTSS, dental, the things that are, not in all of them?
I'd want to propose, I think we're saying the same thing. You have 3 plans here. And if we're missing one again, is to do a 3-plan model approach. Okay. Because in that, you're going to see the layering that you're talking about. It's something that the commission can understand, and it's kind of a manageable construct. So my proposal back would be is, and I can tell you can do it. Milliman can do it. They got all the data. They can do it. Is to do Medicaid. I'm going to put. I would ask for PEB is, by the way, is PEB-SEB. That's important in something. PEB-SEB. And the essential health benefits, but the only thing I keep asking for on that is back to PEB. That's different than the plan that we're talking about, the 1 year, Pam, the
Cascades.
And if that's different, then we have those 4. Okay. You can see within that analysis where the differences are.
Okay.
Or is it just kind of, starting here and just adding? These are good benchmarks to build off of. Mm-hmm. And I'll say one other thing. Having an actuary do it, they go into claims data, right? They're going to roll it up for us, but they go into claims level so you can really get a sense of where the differences are. And it's not on the price side, but on the benefit side that you and I can't do when we're just reading,
right.
benefits. But they can do it. And I think in a reasonably rolled up form, it would be very, very useful to all of us. One last thing is that the Universal Healthcare Commission's got dollars to do it.
They do.
Roger, on that note, what you were talking about, Roger, when they do that actuarial analysis with the 4 layers, now, does that talk about the scalability as you're looking at the population of this is the Medicaid and PEB-SEB, but then you're going to scale that up to cover private market and so on?
Yeah, you're going to just see, I think we're saying the same. You're having, rather than 1 line that you scale up, you're having 4 columns with the rows underneath them. So they are scalable. You can, yes, it is. I just think that by having these as those column headers, it gives a context for folks, if I'm making sense.
David?
Thanks. As I propose just a slight adaptation to what Roger's saying. I think if you start with Cascade Care as the anchor point, because a lot of thoughtful people went through the process of trying to figure out what makes sense to offer on the exchange that's essential, et cetera. And with that, you can see the impact on premium as you go from silver to gold to bronze, from silver to gold to platinum. The actuarial value goes from 70% to 80% to 90%. So you can see how the cost sharing moves and the impact on premium. And then you can benchmark, well, how does Medicaid differ from that? Does Medicaid cover anything different? And then does PEB cover anything different?
Any other comments?
It sounds like you have agreement.
Okay.
Yeah,
Gary, anything?
Thank you. No, thank you.
No, thank you.
That's helpful.
I know it's late in the day and later for some folks who I think might be on the East Coast. So just appreciate you continuing to be here for this.
I think we have to come back in a future meeting about some of the point of service cost sharing, the purpose of cost sharing, prior auth, and those things. But I think you have the fundamentals that you need to go back to the Universal Healthcare Commission.
We do, and we will be coming back to this. Now is March, so in May we'll be coming back, and hopefully we can get that analysis and go deeper into some of the things that you started raising today about the cost sharing, etc. So.
Can I ask one small favor and I'll shut up? Where you see UMP, this is a small one, but you have PEB there. Could you do a slash and put SEB?
Of course. And I think there's actually legislation that they have to combine, don't they? That just passed, right? Yeah.
Politically important.
Yes. So, I mean, changes like moment by moment. So, yeah. Thank you. Pam.
Okay. Thank you, Liz. That was great. So I want to just close the meeting. Thank everybody for a really productive meeting, excellent conversations and discussion and good questions. Thanks to Whole Washington and HMA for the presentations. This discussion and recommendations will be shared with the commission at their next meeting. And our next Zoom is on May 9th. So thanks everyone so much.
Yeah.
See you next time.
Bye-bye.